we've got Hennie joining us from Tygerberg, and over the next few weeks we're going to be looking at some aspects of trauma. For those of you that don't know Hennie, he used to bang his head against the walls at Kaya, and now he bangs his head against the wall at Tygerberg. The only difference is I think the walls are a little bit thicker, but he's an EM physician and he's trying to sort of improve things at Tygerberg bit by bit, I would imagine. We're going to be trying out a few different things during teaching today, and hopefully you guys will be able to participate. So if you are on a phone, you will notice in the chat section that we've put up a poll. It's A, B, C, D. There will be some questions during the presentation whilst we're chatting, and you guys are welcome to answer those. It's probably best if you're going to answer all of them, or if you're not going to add an answer during the session, to raise your vote, because we're going to be using the same poll just because it's easier than having to repopulate the form. And you can switch between the chat section on your phone and the video as we go along. Okay. Yeah, so I don't know if there's anything we want to chat a little bit about the next few weeks. We've got a social event happening next week, and the following week we've got Conrad chatting to us, and then Deirdre from Groote Skeer, who's going to be joining us as well. So those are a few things to look forward to. I'm going to share my screen and we're going to jump straight in. Okay. Camlin, I've got you on my screen. You've got the presentation up? Okay. Camlin, I'm going to ask you to switch off your camera because I don't know how to switch between, or let me see if I can pin Hennie.
Yeah, just click on the bottom. So what I'm seeing is what everyone else is seeing. So if you just click on your sort of thing on the bottom, it'll move me away. But I can put nothing off.
Sorry, guys.
You need me to do anything?
No, you don't need to do anything. It looks good, but I just can't see any, but it's okay. We'll just have a chat without any. Maybe just put your camera off, or I don't know how to.
It is off.
Okay.
Luke, do you want me to pin Hennie? I can pin
if you
Hennie.
don't mind, because otherwise it's a bit difficult to have a conversation with him.
Yeah, so look, I'm recording it, so whatever I'm seeing is going to be recorded, and so far it looks good. You might just have to improvise if you can't see Hennie on your side for the sake of this session, I guess. Yeah.
Okay, cool. So what we're going to be looking at during this session is and why we've asked Hennie to join us is because he has experienced both of our system and also the UK system, having worked there, and specifically around trauma teams and some aspects around trauma teams. We're just going to give the poll a quick try. So for those of you that are on the phone, it's probably easier for me to read and then for you to go across. So what was your first home delivery post-lockdown? Cheap booze, expensive wine, pretty open-toed shoes. And for some of you, I'm still waiting for something to roll in my Rizla. So whilst Cameron puts that in the chat, we're just going to give it a try and see whether it works and whether it's useful during the rest of the session. So jump onto that so long. Okay, so we're going to be using a video and then stopping the video intermittently and having a chat about some of the aspects. And so here we go.
Okay, so your screen has stopped sharing now.
Sorry?
Yeah, your screen has stopped sharing now. We're just populating in the meantime, just to give you an update, and the poll seems to be working. We've got 8 responses so far. It seems like only 25% of the people bought cheap booze. A bit disappointing.
Okay, that should be sharing.
Now it's good.
All right, folks, let's have a pre.
And you've got sound.
Please.
Yeah.
Chrissy Coleman, ER resident, Airway.
I'm Chris, secondary paramedic.
Anita Stride.
Jackson, Tech.
Brenda, primary. Tyler, trauma junior, secondary service. Julie, respiratory therapy.
All right, I'm Rick Miller, the trauma team leader. Report says that we have an 18-year-old that was the unrestrained passenger involved in a high-speed motor vehicle collision. The driver was killed at the scene. This patient was unresponsive at the scene, has now been intubated, and there's been reports of hypotension. And life flight's bringing the patient in. Any questions?
Okay, so Hennie, my first impression is that there's a lot of people seated around, or have, there were a lot of people around the table, and and that there are a lot of different skill sets around that table, and you know, your local knowledge and working in teams. What is your impression around sort of trauma teams, and what do you think about the things that we should be doing in our setting?
The key thing, and that we're trying to establish, is a pre-alert. So you can see they're standing around waiting for the patient. In many of our instances, we don't get a proper pre-alert. So we can't stand around, we can't prep, we can't wait for the patient. So that's the one thing of note that we're trying to improve. So in district hospitals like Khalicha Mitchell's plan, there's that board, the EMS board, which essentially gives you a list of what's coming and what's going, but it's not necessarily a proper phone call, red phone, pre-alert, this is what's coming, you got 15 minutes. That's the first thing. The second thing is about the teams. You want me to expand on the teams?
Yes, please.
So that's an American video.
Sure. Yeah, expand on the teams for us.
So that's an American video. The teams in the UK are slightly different. Just for the guys that haven't worked in England, there's things called major trauma centres. There's 28 MTCs in the UK. What a major trauma centre is essentially like a level 1 trauma centre here and in the US. Then there's what they call trauma centres, which are smaller centres. But the MTC allows you to have a team that we're talking about. That team has got a lot of people. The key is that the team is led by the EM physician, which is important. So EM in the UK is big. We run the units. The unit that I worked most recently in had 25 EM consultants, 4 of us on the floor at any one point in time. So EM-led team leader, and then you have your various disciplines around you, and that varies from country to country. The problem with that is that you can get people heavy, too many, what did they say? Too many chiefs, too few subordinates. So in this country, what we're trying to establish at Tygerberg is a bit different. You want me to tell you?
Well, I think we'll get into the integration of that towards the end, but I think the important thing is sort of the role identification.
So role identification. Okay, sure. So role identification in the UK system essentially is team leader. Then it would be essentially a airway doctor, which is normally the ITU registrar consultant. It would be a primary survey doctor / airway doctor, depending on if there's 2 of them. It would be a circulation doctor, which is either the general surgical registrar consultant or orthopedic surgical registrar consultant. There's then a nurse team leader, which runs and collects the drugs. There's a nurse second, which helps just with fetching and carrying. Then there's a scribe. That's essentially what you're looking at in the UK.
So quite a big team. Quite a big team, and obviously something that's not necessarily realistic here, but I mean, obviously clearly defined roles for each of those team members. Yeah. Okay, so we're just going to move on to the next part.
We've lost sound.
Thank you. I'm going to need to stop sharing. I'll get back to it now.
Hennie, in the meantime, if maybe you could just run us through the comparison in terms of the team that you've set up. I know that Luke is going to discuss it more in detail with you.
So what we're trying to establish, at least at Tygerberg, and what we sort of started a little bit at Khalicha, is it's team leader, EM physician, Dr. 1, Dr. 2, Nurse 1, Nurse 2. That's something that they do to an extent at Joburg Gen 163 in Baragwanath. So team leader is EM physician, Dr. 1 is airway doc, Dr. 2 is circulation doc, Nurse 1 is medications and medications only, and Nurse 2 is monitoring and runner. We don't have the luxury of a scribe. And remember, it's a one-way communication. There's no shouting across to each other. There's no shouting to any other staff members. The talking is from the Nurse 1, Nurse 2, Doc 1, Doc 2 to team leader, and team leader then talks back. That is the key, essentially. Does that make sense?
It does.
Yeah, that
makes
perfect sense. I'd be interested
there's much
now
more-
for the rest of the group to see how your team that you've developed for Tygerberg feeds into what we see in the video and how it differs from what's been suggested in the video. So maybe just keep an eye out for that, and Luke will tie it all up together.
Okay, already in the video, if you look, there's too many people. There's two people at the head of the bed. There's 3 people on our left. There's 2 on the right. You must be careful about being too many heavy, because then there's too many opinions. That's why it essentially should be 1 EM physician in charge.
Yeah. So I think we're going to try share the audio again, and it should come through. Can you hear that?
No,
No.
still no sound.
So
So let me just also add, so then while you're trying to fix that, so the English
Sure.
system, the MTC, everyone doesn't all stay at the resus for the full resus. As the resus develops and you realize that airway is good, no need for intubation, etc., you excuse that team. If there's no general surgical intervention needed, you excuse the general surgeons, as you do with the orthopedic surgeons. So if the patient's essentially stable, you're happy to go to scan just with your less staff, then they're excused and they get on with what they need to do elsewhere in the hospital. And that's important.
And so then, Hennie, would your...
High-speed motor was unresponsive.
Go ahead, Luke.
Sure.
I think you're
Sure.
running.
Okay, cool. And you guys can hear that? I'm just going to go back a little bit.
Intubated, and there's been reports of hypotension, and life flight's bringing the patient in. Any questions?
Game on.
This patient's intubated with an 8.02. There's good breath sounds. Pulse ox is 100%. Bring the
Okay.
down just a little bit.
Confirm color change, please. All right, we have good color change.
All right. Hook them up to our monitors. Let's carefully move them over. Take them off the bag as we move them over.
Equal bilateral breath sounds. All right, ready, guys? 1, 2, 3. You get a good right femoral pulse. Okay, color changes reconfirmed.
Okay, let's get initial vital signs, please.
There's still equal breath sounds. Bilateral femoral pulses. Dr. McGowan on the last 4 with the 6 please. Dr. McGowan on the last 4.
Right after vital signs, we'll get a chest x-ray, please.
Engage on the right.
Blood pressure.
I have a pressure 84 palpated.
All right, 84 palpated. This patient is hypotensive, folks. Let's get a chest x-ray and a quick report, please.
All right, 18 to 20-year-old unrestrained passenger car versus a bridge abutment. Massive damage to the front of the vehicle. The driver was unrestrained and was DOA at the scene. EMS reports he was initially awake and just confused and not acting right. When I met him, he was becoming verbally uncooperative in the aircraft. That progressed to full-out combativeness. He got a standard Vanderbilt RSI that was uncomplicated. That's an 8.0 at 23 with good breath sounds. He has been gradually becoming more tachycardic. I met him at about 100. He's up to 120 right now. His blood pressure was initially 110 for EMS, and it's been decreasing in flight. He's had 2 liters of fluid. He's not had follow-up sedation or paralytics because we were so close in. The rest of his secondary is unremarkable. His long bones are without any gross deformity. Like I said, 2 16s. We're just shy of 2 liters of crystalloid on board. Do you have any questions?
You want me to comment?
No, not comment yet. Basically, I know you commented on too many people around the table, but I don't know if you noticed it, but each of those people are sort of in their own little bubble. They're very focused on their task. And, it's something that, yes, maybe we're so much used to multitasking, but it feels very quiet. I mean, I understand there's a team leader, but, each of those people are involved in their own individual task, and almost all the communication goes through their team leader. So although you say, I think that is a very efficient way of doing things, but obviously with our numbers, it has to be a little bit, with the number of people that we have in our teams, it has to be a little bit different. Is that just because I haven't been doing it properly? I mean, that unit or that resus appears rather quiet.
It's too quiet. There's not enough communication. So if you run these resuses in the MTC system, as team leader, you talking. So I would, let's rather go Dr. 1, Dr. 2. So it's Dr. 1, tell me about the airway. Are you happy? Is it open, maintained? Do you need to intubate? Yes or no? This guy's already arrived intubated. Then it would be Dr. 2, tell me about circulation, tell me about your survey, and then he reports back to me. All right, and then monitoring, I say, nurse 2, monitoring, give me a run of vitals, please. And then she gives me a run of vitals.
And you're sort of running through that system in your head as you're going.
Through that system. So I'm doing you running as team leader, you're running through your ABCDE via Dr. 1, Dr. 2. You're asking nurse 2 for your vitals. Nurse 1 is essentially just your RN who's going to collect medication for you, which you don't need as yet. There's a little bit, the communications, they're a bit quiet. Maybe they're tired.
Yeah. No, it's just I mean, I know it's part of a sim, but it feels rather quiet in terms of the communication. But the one thing about it is that everything does go through the team leader. There isn't any communication between members of the team. Or everything comes back to the team leader.
I think the more the team leader communicates with the team members, the better they feel, the more relaxed everyone feels actually. If there's too much silence and you just hear a lot of beeping and tachycardias and alarms, people start getting a bit tense. The other thing is that you always redo your primary surveys and you redo it through the same people again. As you guys know, if there's a condition change, you redo your primary survey. And a big thing of note is that 2 liters of crystalloids, but that's another lecture altogether.
Yes, we do bring it up a little bit later. I'm just going to pause briefly. I just want to move the slide forward slightly. Sorry. I'm going to need to jump. Restart.
Blood pressure is on.
Okay. Okay. So, guys.
No, excellent report. Thank you.
The next poll. What is our achievable trauma team size in your unit? So obviously Hennie has a number around 5 there. Do you think that's achievable at our district levels to have 4 to 5? A is 3, B is 4 to 5, C is 6 to 7, and D is greater than 7. So whilst we continue, you guys can think a little bit about that. We've spoken a little bit about the communication, Hennie. Now, the EMS crew have done a handover quite far.
Luke, I think maybe let's do you mind just give them about a minute or so while this thing updates for people to vote, because it's hard to concentrate on the two things as I'm looking at it on my screen as well. So far, we've got already 12 votes. It looks like people are favoring option A. So we've got about 41% of people favoring option A so far. Nobody, well, there's only 2 people that have gone for 6 to 7. Actually, that's changing. Yeah, so yeah, so it looks like the majority right now out of we've got about 13 responses. So from the lot, we've got close to 50% response, and it looks like we're heading towards a split between option A. So 50% say option A and 42% say option B.
Okay, so I mean, quite small sizes to our teams, and obviously that has an impact on what we can achieve and the task allocation. We'll talk a little bit about that right at the end, but I want to just go back to some of the communication and the EMS crew presenting quite delayed into the sequence. It's not something that I'm used to. They obviously did the initial sort of transfer across, and if you noticed, a primary survey whilst well, at least airway and breathing whilst he was on the stretcher. But that sequence for the handover from EMS being a little bit delayed, it's not something we're particularly good at.
It's unit specific though. Obviously that's how they do it in that unit. But doing the primary survey on the stretcher is not something that's generally done in most areas. You put the patient on the scoop, put him on the bed. You then get an immediate handover from EMS, take the scoop off, and then do your assessments. That's how it's normally done.
And do you favor any structured format to that communication, or is it, or do you suggest a structured format?
From who? The pre-hospital paramedic?
From EMS, yeah, from pre-hospital paramedic to the doctors or the nurses,
look,
whoever's taking the handover.
We must admit, I mean, the pre-hospital handovers are very poor in this country, unfortunately. Depending on the skill level, if they're a paramedic, it's better, but if they're lower level, you know, BLS or LS crews, it's a problem. Formats obviously not necessarily, must start with mechanism, etc. You know, number of blue patients, mechanism, injuries on scene, patients' vitals, injuries that they've noted, management they've given, change of vitals with the patient, and on scene condition. So no real structure, no.
Yeah, I mean, I don't, in my practice, there hasn't really been any real structure, unless sometimes in sort of the private side where some of the crews are a little bit more skilled or a little bit more empowered to do formal handovers. So the next poll for you guys is really related to that communication, particularly with our EMS. I'm not looking so much at the private guys, but which communication tool have you seen used by EMS? DMIST, IMIST AMBO, IS bar, and you don't see any formal tool being used. I'm pretty sure it's going to be D, but it has actually been a little while since I've worked in an EC.
The UK guys,
some time.
They work
yes,
with
go
an
for it.
ATMIST. They call it an ATMIST.
ATMIST. So yeah, there are various tools. We spoke a little bit about them previously, just very briefly. But you're going to say something, Hennie?
No, I forgot what the A was.
Don't worry, I did exactly the same thing when I was going through DMIST. So I decided to put them on the screen for everyone so that they could figure it out themselves. It's always difficult when you're off the top of your head. Mm. But I think basically having some structure to the handover is useful. Otherwise, lots of things end up being missed. Cameron, do we have any ideas to the poll?
Yeah, so it looks like we've got, there seems to be a relatively even split. Majority, as we would expect, 50% saying that they don't see a formal tool being used by EMS, whereas we've got 3 people, so 16% that say they've seen DMIST used, and then IMIST AMBO being used by 22%, and just a single person has seen IS bar.
Okay, good. So I'm just going to move on to the video.
Luke, there's no
volume again. Sorry, guys. For some reason, it's switching off the audio each time I stop it. I think I'm just going to play through the video, and then we can come back and just chat about some of it.
Sure. We've got a hand up from Lauren, if you maybe want to give it a chance.
Hand up.
Let's get a
Go for it, Lauren. Let me just play through the video, and then we can go back to some of the aspects, because I think the sharing of the audio is the issue on my side. Just
fast exam right after our secondary survey, quickly, please.
All right, from the top, pupils are free and equally reactive. TMs are clear. I don't appreciate any facial trauma or scalp trauma. Trachea is midline, anterior neck is clear. Clavicle is stable. No echobosis or no crumbles on the chest wall. You just have a little bit of echobosis on the lower abdomen. Just a little bit firm. His pelvis was stable. His extremities, I didn't see any deformities, and he had good pulses, DP and bilateral radials as well.
Heart rate's 130, sats are 100%. Checking another pressure.
First unit's up.
Okay.
Third by B. Third by B.
Start the second unit. Second unit's up.
Fast exam is positive for fluid stripes in the right upper and left upper quadrants, also in the pelvis. No pericardial fluid.
Okay, folks, he's been hypotensive, receding blood. We're going to proceed towards operative intervention. I'd like to initiate the trauma exsanguination protocol. Please get the blood bank on the phone. Let's call the operating room and head to the OR, please.
Okay, so I just want to take a step back to just before she starts her sort of secondary survey, Hennie, and this patient had already received 2 liters of crystalloid. In our setting, most of the time at our district level hospitals, patients don't come in intubated, and sometimes at Tygerberg and Rsi, and often that intubation decision and intubation of the hypotensive patient is something that we do in our units, and that there is a lot of risk involved. How would you suggest that we approach sort of those severe hypotensive patients when we do need to manage an airway or intubate them?
So in terms of fluid strategy, for a start, no crystalloids. If you need to intubate a hypotensive patient, you can give a crystalloid bolus. We normally advocate 250 to 500 cc normal saline, not ringers. And then you need to start with your FDP infusions. So 15 ml per kilo FDP. So if you can potentially try and get 1 bottle of FDP in prior to your RSI, you're in a better space. Obviously, choice of your Rsi drugs. We normally, guys, use etomidate, whether it's rock, whether it's sux, whether it's ketamine. We prefer ketamine in a hypotensive patient versus etomidate. I prefer rux versus suck, rock versus sux. What else? Inotrope usage, definitely not. We only use inotropes when the tank is full. So don't think of using inotropes, whether it's peripheral vasodilators or alpha betas. Does that answer the question? What else am I missing there?
Yeah, I think it does. I mean, I just often see, even particularly at Rsi, and I don't know what the practice is at Tygerberg, but inotropes being used.
No.
And it's something that so I'm always hesitant about, but definitely not improving outcomes.
So clearly no inotropes. We fry the kidneys, and it's definitely a practice that's significantly frowned on. It's inotrope usage in a trauma patient without proper fluid resuscitation just shows inexperience. Okay, so don't do that. Rather delay intubation as far as you can. If it's not a gunshot face or the neck isn't crushed or a gunshot neck, you can use alternative airway devices, supraglottic devices. You can just bag valve mask them. You can stick in an LMA, bag them up, get your fluids in, get the volume status to an acceptable level, and then you can do your formal RSI if you're worried. Does that make sense?
Yeah, totally. And I think it's sort of the message around circulation being the priority, because that's what kills trauma patients.
Absolutely. And on circulation,
unless there's an obvious airway problem.
Yeah. So, and in trauma patients, if you work in trauma a lot, they're not medical patients. A lot of the time, trauma airways are generally okay, unless it's, as I said, gunshot face, crushed face, assault, etc., stabbed through the face. You've got time airway-wise. You can do a bit of hyperoxygenation. You can put in your airways, your supraglottic stuff, manage the circulation, because they generally come in with thoracic abdominal injuries, fractured pelvis, gunshot chest. Sort that out first, then get your airway.
Sure. I think this specific patient had come in intubated, and I think had been intubated on the basis of sort of a cognitive change or a level of consciousness on the basis of his hypotension. And obviously it's high risk if you're not managing the hypotension adequately. So, I think something...
You must watch out with crash intubations. So, these guys, the whole thing around just sticking in a tube without paralyzing the patient is also, that's looking for trouble, because they still have a gag. So just be careful of that. We still need to fully RSI patients, even with low GCSs and hypotension. And fluid strategy, I don't know if you're going to go around that, but fluid strategy is something that's definitely changing.
Tell us.
Well, so we're going to start a study fairly soon at Tygerberg. Whole blood is the king at the moment. Eh? So it's no crystalloid, no colloid. It's FDPs, TXA, emergency blood, waiting for whole blood. So the big trauma centers, there's 4 to 5 in the US currently that are keeping 6 to 8 units of whole blood on standby. It lasts for 28 days in a fridge. And that is your go-to fluid of choice in a facility that has that available. Okay.
And at district level, obviously, that's where we spend most of our time. the emergency blood that we have available and FDPs would be our initial go-to.
That's right.
And
the catchphrase is that we bleed whole blood, we don't bleed component therapy. So one-to-one component therapy is something that blood banks really started in the 70s for various reasons, but we don't bleed component therapy, we bleed whole blood.
Sure. And I mean, that ability at district level is possible, I suppose, over sort of critical weekends. But do you think it would really make a difference to outcomes? Because most of the time we need to get our patients across either to a trauma or to Tygerberg or Groote Schuur, or potentially theatres at the facilities, and we have limited blood stocks.
So the outcomes, most certainly, if you chat to the trauma surgeons here and overseas, is that a patient that's been given whole blood intra-op just looks better, oozes less, there's better coagulation, there's less cautery needed versus a patient that was given emergency blood and component therapy. So, I mean, our benchmark is our surgical expertise, surgical ICU, discharge from ICU and walk out of the facility. And the whole blood patients, essentially, they are better, they do better. And that's the study that we want to start with Prof. Stan in the trauma unit. We want to compare the component therapy versus whole blood patients, ICU stay, and then discharge.
Okay. And then in the video, you see the use of an eFast, and it's definitely something that we use a lot of, and sometimes probably overuse it or overcall or undercall things, and it is a risk. How do you think the eFast is best used to sort of improve patient outcomes and help us make decisions at district level? Not so much at where you have a CT scan available, but at sort of our level where we don't have those a CT scan immediately available.
No, eFast is fully accepted here, the US, UK. I don't know if they did the lungs though. I didn't see them doing the lungs.
No, they didn't do the lungs.
So and the eFast is actually done in the MTCs by the team leader. So in between your primary and secondary done by various members, the team leader will very quietly make his way, quickly do the eFast and then report to the team. In our Dr. 1, Dr. 2 scenario, it would probably end up being Dr. 2 if you don't have a team leader. But most certainly accepted, done, as you know, binary, yes or no, free fluid unstable theatre, free fluid stable, plus or minus CT.
Okay. And I think that sort of goes into our, well, not yet, in terms of the sequence, but yes,
we have a few questions on the two previous polls. I don't know if you're able to stop here and take on that before we go to the next one, because there's quite a lot here. So Hennie, this is for you. So going back to the first one, so we had a first poll about the trauma team sizes, and so there's sort of a two-part question. So it seems as though the general feeling here is that they think we can manage 3, maybe 4 to 5. In your experience, what do you think is the sub minimum, and how do you advocate we assign roles given your knowledge of what goes on in our district hospitals?
2 docs, 1 nurse. That's minimum. Okay, so 1 doctor must be airway, 1 doctor must be circulation, and at least 1 nurse to run for drugs. You can't run less than that.
Okay, and then just so from personal experience, it's sometimes difficult. We know that most trauma comes in at the night, and at night you sometimes have an ad hoc team that you may not be familiar with, and so if you have not had this time to get used to your staff or get too used to who you're actually working with, some people don't even know the names of the other people on the teams that they're with. How do you approach that situation where you as say for instance, a registrar are coming onto shift, you're not too familiar with the teams and your trauma is starting to roll through the door? Do you pause? Do you set up a sort of a huddle at your night shift and say, guys, this is what our roles are for today when a major trauma happens to come in? Or do you just take whoever seems to be keen that happens to be in the room in the recess at that time?
No, it's exactly what you said. So we tried at Khayelitsha, I'd say about a year ago. There was a notice board in recess on the left. As you come in, roles are allocated. So team leader, Dr. 1, Dr. 2, nurse 1, nurse 2. So as your shift starts, have a whiteboard somewhere, allocate the roles, and it's also at that point you can say, oh, listen, I'm not quite sure what my duties are. And then in a 5-minute huddle pre-shift, you just decide, you sort of explain and emphasize what the duties are.
Yeah, I think that's always a difficult thing for, especially sometimes if you go into a unit, because it doesn't, from what I understand, it's not always the most senior person that has to be the team leader. There might be somebody that's got a better command of the unit that has been in that particular unit for most time, but there needs to be that communication and that understanding that, I might be the best airway person, maybe that's my role for today, or, type thing.
Yeah, that's right. But decide that before the shift.
Okay, and then, sorry, and then on the next poll, so we spoke about the different tools for EMS handovers, whether they're coming from private, public, wherever you're working. I think the most important thing there is that we all speak the same language. So if you could recommend one sort of communication strategy for handing over between EMS to doctor or EMS to nurse, or because I know if you worked at PAL, you get the system where EMS brings the patient, hands over to the nurse then assesses and then comes to you and says, I think this person is sicker than the other person. If you work in another facility, it's EMS comes straight to the doctor, whoever happens to be there. Sometimes patients come in and they get sort of the pseudo triage with an ultrasound to say whether your stabbed chest is so severe that you need to sit inside or not. What if you could create, or you could have the ideal standardized system that could work across our district hospitals, across our sort of tertiary hospitals, so that we all speak the same language no matter where we work? What would that be?
So the DMIST or ATMIST is the best method. The other thing is that red and orange patients should be doctor handover only. Okay. A nurse shouldn't take responsibility for accepting a handover of red and orange. And the red, anyway, in a trauma patient should be in this team structure of this video we're watching. So yellow and green, yes, the nurse can hand over and come report some vitals, but am I getting that right? Yellow, green, yellow, orange, red.
Yes.
Orange,
you're getting it
red.
right. You're getting it right.
Should most certainly be a doctor handover. And we're trying to establish that in the trauma unit. We've redone the clerking booklet, which has that in effect in terms of handover. The other way to do it, and what we're going to try and institute, but I haven't done that yet, is have a little card, a little laminated card that we're going to just hand to the paramedic with what we'd like to know from them with every patient. We're going to see if that works. But that might seem a bit like, teacher student. Like
I think the big thing is sort of probably engaging EMS and sort of upskilling, but also at the same time involving them more, because there are paramedics who are really interested, but most of the time they sort of get short shrift and treated badly, and so their investment in terms of handover or acknowledging each other is pretty poor at the best of times.
Exactly.
I think we can all work on it, definitely.
And then the last question we have. Sorry, Luke, this is the last one that we have.
Ooh, good. No, it's good.
So Hennie, we've got a question that's related to, you mentioned that we go, wherever the patient is, they get their sort of a revised ATLS 500 clear fluid if you're unable to give them blood initially. And then you mentioned FDPs. Is that something that we think is locally specific, or is it because, was this something that you'd say on the phone to the CHC while waiting transfer if they did have access to FDPs? Or, what's the reasoning behind that?
So the FDP story is a long story and interesting story. I mean, it's locally specific in South Africa because of our blood bank, etc., and our resources. But it's come to the fore from the most recent Iraq-Afghanistan conflicts. The US Special Forces guys are using it. And it's been shown to be the most effective in a pre-hospital type situation and arriving at a facility situation. The Israeli Defense Force uses FDP and FDP only pre-hospital. The reason we say FDP in this environment, not so much at tertiary, but at district and CHC level, is because you're essentially in a pre-hospital environment, aren't you? At a lot of those levels, you've got no blood bank on site, and a lot of those facilities don't have even emergency blood. So your best option at that stage would be FDPs. There's 3 FDP products made, one in France, one in Germany, and one in South Africa in the world. So, and we've been at the forefront with FDP usage. I mean, we started using it in the 80s for gynae indications, then it became trauma indications. KwaZulu-Natal had it for years before we finally got it in the Western Cape. It's now standard throughout the world. you're not going to find European units, American units, and UK units using FDP though. Okay, they in hospitals they would go straight to the component therapy, one-to-one component therapy. So you're not going to find it being used there. They're not too convinced to use FDP in a hospital setting. And their component therapy, they use rapid infusers. They're called Bell-Sol machines. And you can get a massive transfusion protocol in someone's body with 2 wide-bore catheters in about 6 to 8 minutes. So it definitely varies from unit to unit, but we're pushing FDPs in this country because of resource limitation. Does that make sense?
No, that makes complete sense.
It definitely makes sense.
Yeah.
We obviously don't have access to blood and components, so
yeah,
and it's cheaper and you can store it. And
you'll get foreigners coming along and saying, "Listen, you guys have got a blood bank on site, Tygerberg and Kalicha now. Why are you giving FDPs?" There's no proper answer to that. It's just we like using FDP as an initial charge your line, then order your blood products. That's my answer to the foreign guys saying, but just go straight to component therapy. Well, the reflex answer now in a few months is going to be just go straight to
and have you had any sort of experience with any of these, TEGs or ROTEMs with the influence of FDPs on that? I mean, has it been beneficial, detrimental, or it doesn't really matter?
We don't have a TEG here. I wish we did, but and in the European units, UK, we don't use FDP, so you can't compare it with the TEG there. So no, it's the FDP evidence is it's lower tiered evidence, but it is there and it needs to be more validated, sure.
But it does have
better than crystalloid and colloid.
It's better than crystalloid and colloid, and it is useful in our setting.
Yes.
Yeah, sure. I'm going to skip the next poll just so that we can move on. A lot of our patients are critically ill in our district levels, and there's often a big delay. In this video, they're off to theatre pretty quickly, and they have theatres available very quickly. And in trauma centres, that's the idea. But at district level, we don't have access to a theatre immediately, and so there's often delays. And what can we be doing for those critically ill trauma patients whilst they wait? We need to stop the bleeding, but we can't access that if it's intra-abdominal. But they may have fractures or other things. What should we be doing to improve their outcomes?
It depends on what's wrong. So
sure.
If it's thoracic trauma, bilateral ICDs. Fluid therapy, do you need a central line or wide bore catheters? Remember, central line is only for inotropes after the tank is full. You can bind the pelvis, so pelvic binding is now back in fashion. Okay, pelvic binding can help a lot. You can do pelvic packing. Have you guys seen that done? You can do a mini laparotomy below the umbilicus, a vertical incision, pack the pelvis with swabs. We've done that twice in Tygerberg in the front room. Your diagnostics, I see here, poll 4, the x-rays that we do are only chest and pelvis. It's not lateral C-spine, anything like that anymore. It's chest and pelvis, and then it's pan-CT if you're in that facility, or directed CT. And then
you obviously don't take your, and that's in a stable patient. I mean, if it was unstable or ongoing blood loss, you would go straight to laparotomy, or would you still advise a CT?
No, there's a caveat to that. Have you guys heard of hybrid theatres?
No.
So a hybrid theatre is a theatre that's got a CT in it, and they're normally adjacent to a trauma centre. In the big trauma units, your aim is to get pan CT within 10 minutes, which is achievable. If the patient's unstable and you still want CT, you go to a hybrid theatre where you'll get the scan while you're having your midline incision being done, from xiphisternum to symphysis. So it is possible. So the adage of not going to CT unstable doesn't fly in a hybrid theatre. But everywhere else it does, yes. No CT if you're unstable, straight to theatre.
So obviously trying to stop blood loss, splinting bones, binding pelvis, ICDs.
Put in your drains.
Keeping them temperature control.
Sure.
not giving them too much crystalloid. If that's all
lethal
you
triad, yeah. And then TXA, everyone's forgetting about TXA. Yes?
Yes, no, sometimes. I think sometimes in the, if it's not part of your immediate as the patient lands, then there's sort of this delay, and suddenly you're like, well, should we now give it? We've delayed it. And often our patients present late, and so there is some debate as to at what point is too late. And if there's ongoing bleeding, you can probably argue that you should still be giving it. But,
yeah, so within 3 hours, if you accurately got your timing right. Remember, we're not all going to work in this system where things are delayed. No one knows what's going on. You might end up working in a system where the patient's picked up from scene within 5 minutes of injury. So TXA is definitely justified. So it's used, it's justified. I don't understand why New Somerset, someone there doesn't like TXA. There's debate here and there, who knows where, but if it's used internationally, particularly in the major trauma teams in our military austere type environment, and those are the patients we see, let's use it.
Okay.
Yeah, I think that topic is very important because there's once again this concept of in different practices. So if you go to certain other major trauma centers which shan't be named, you need to go and beg gynae to get your TXA to give to a patient that's worthy of getting TXA. I mean, it brings up the discussion for crash 2, crash 3, but that we can do at a later stage. But in terms of that major trauma, it's not, for some reason, there's no universal buy-in, especially in our Cape Metro, and I don't know why that is.
It doesn't make sense. I mean, you work at Baragwanath 163, TXA is used, and they probably see more trauma in one night than what we see in 3 nights.
Sorry, guys. Yeah, I mean, I think the evidence for TXA in our setting is that it's useful, and it's becoming increasingly useful. And it's just about when and remembering to give it, and that you should continue it with an infusion.
Yes, of course.
Yeah. So that we give it properly, and that it's not just, it's in, and then we forget to do the rest of it, because, if you're not doing the whole thing, you probably aren't getting the benefit.
Yeah, that's right.
And then we've already spoken a little bit about the integration into our practice. I mean, obviously that's your Tygerberg Hospital plan. The doctors, our poll suggested that we've probably got 3 that we have access to. I mean, there's definitely more people on the floor that, in terms from the nursing side, and I suppose, we need to be able to use 3 if that's what you would suggest as the lowest number. Yeah.
So that Tygerberg plan. Sorry.
Go for it.
The Tygerberg plan is that's what we've now only recently managed to get into C1D East, which is our 6-bed resus area. This is the emergency plan that we're currently using, and we're doing our utmost best to. The key to this is that you need a pre-alert, so everyone gets ready. And then for the future, Dr. 1 is going to be the ICU A1 surgery registrar. Dr. 2 is going to be the trauma surgeon on call, an orthopedic surgeon on call together. The team leader will probably be, when a consultant's not around, the EM registrar or one of the medical officers. And then the nurse 1, nurse 2 will stay the same. So we're going to integrate the ICU, one of the ICU doctors, A1 surgical ICU doctors, the trauma surgery reg on, the ortho surgery reg on, as part of a hospital trauma call. And then that will be announced over the PA system when we've got a decent pre-alert. That's in the future.
Okay, and then I'm just going to bring up, Hennie, you send me through just these 2. So this is something that you sent to me earlier today, just with regards to sort of that pre-alert and information that should be transferred, and sort of some of the structure behind trauma calls and the trauma teams. I don't know if you want to go into it a little bit. I was going to bring it up earlier, but just with the tech issues.
It's so important. So the document on the screens left and our left, the one that says Trauma Network, Trauma Unity, MTC. This is there's the EM physician who's in charge of the unit at that point in time. The phone rings, he answers the phone. It's a red phone, of course. And then it's the EMS. Normally they're phoning from a moving helicopter, the moving ambulance, and they give you all the information that's in the document you see in front of you. So, okay, not the hospital number, but the name, age, time of incident, mechanism, their injuries, finding, etc. They give you the vitals, they give you the TXA dose that was given, yes or no, and then disability and spinal injury. Treatment advice is what you tell them to an extent. You'll say to them, well, give a push dose, pressure, yes or no, fluids, what have you. And then you just sign the bottom bit. So that form then gets taken to resus where the open bed is. The staff then get mobilized. Everyone arrives, goes over the PA system, you put on your lead aprons, and then that paper gets read out to the team that's assembled within 10 minutes, and then hopefully the patient arrives in the next 5 minutes. Okay. So that's your key to a proper trauma resus, is a pre-alert. You can't work properly without being told what's arriving.
Hennie, can I pause you there a bit? Just for the other guys on the call, the TXA dose, it says they're dose 1, dose 2. Do you mind just going through what that dose is for dose 1 and dose 2, and how is it given practically? Like what do you tell your nurse to mix up into what bag and fluid and what rate to run it in?
Geez, you're asking me too much now. So it's 1 gram. So the first dose is 1 gram IV within 3 hours over 10 minutes. So it's a slow IV push. Okay, the first dose. So the pre-hospital 1 gram within the first dose. The second, I don't know why it says dose 2. The dose 2 could be patients that are essentially being transferred from a longer. So this trauma unit is in the south of England. So the helicopter would come from, further down. So second dose would be given. Obviously, it's 1 gram over 8 hours. We normally put it in 200 ml saline, as far as I know. 1 gram over 8 hours, and it's important that it's dialed in a dialer flow or in your what's that machine called?
IVAC or a pump or
your pump, your IVAC, over 8 hours. The mistake that we make, at least I know that we did at Kailicha so many times, is you would give the first dose, we'd set up the second dose, patient is ready to go to Tygerberg, no one connects it to an IVAC. Guess what? The second dose, is gone in another 10 minutes because no one's watching it. So we need to be careful of that. So 1 gram, 200 mils over 8 hours, second dose. First dose over 10 minutes.
So the usual thing that I tell them is, the 200 mils run it at 25 mils an hour. And the problem that we find mainly is if there's no infusion pump, it goes into this dialer flow, which is the most unreliable thing on the planet. Yeah. It doesn't give you the right rate. It falls on the floor. Nobody knows. So you've got the situation where instead of giving them the second bolus, now you're giving them nothing. And so these are the small things that, if you are going to give the TXA, give it properly, then only can you say that you think TXA doesn't work.
I find syringe drivers in the pre-hospital setting are the most, how can I say, they give you the least hassle and the least problems. The problem is it's only a 50 ml syringe. So, it's, if you can put the gram in a 50 ml syringe in a driver, maybe that might work. But yeah, so, and the second page, I was going to show you the second page.
Sorry, I'll go back to it. Sorry, Hennie. The second page was the...
what was that second page?
The second page was just dividing into what is an ED trauma call. So smaller teams, essentially, as opposed to a hospital trauma call.
So that's really important. So if you are in a tertiary center, Tygerberg, Fredericia, Barrow, etc., that the ED trauma call would essentially be the kind of sort of yellowish orange type patient where you don't need all the expertise, all the people running around. The hospital trauma call, slightly more ill, but not necessarily hypertensive, unstable. Then you would only have the hospital trauma call and you would limit your numbers. You wouldn't be calling too many patients, like the general surgeon, orthopedic, etc. And then the code red hospital trauma call is everyone. I've got a photograph that I probably should have sent to you. There's the code red calls, you've got sometimes 15 people in the resus area, because it's the consultant with his registrar of every discipline that's come down. So it tends to get very crowded.
Yeah, and often you have to send people away.
Yeah,
you often have to send people away.
Yeah.
Yeah, I mean, that was my experience when I was working in the UK. Is lots of people, and they prefer to overreact, and then it's about who you really need in the setting.
And that's also okay. You know, people on site, people are there. You excuse people. Thank you for coming. See you later. Because, you know, the next trauma call, you need everyone.
Sure.
So they must be used to coming down to the ED.
Okay, just want to go back to. Okay, I don't know if so I think, Hennie, thank you for your time. I think there's been some very useful stuff touched on there. We will be talking a little bit more about some fluids later in the month. What I've put, you guys received the trauma teaching sort of handout, but in terms of the articles that I think are really good, the evolving science of trauma resuscitation is pretty good, and some of the stuff around the FAST, I mean, most of us are using it already and doing it fairly accurately, but depending on where you are in the program, I think it's some of the stuff I've linked to there is useful when you have time to have a look. Hennie, thank you. We're going to do a little bit about decreasing COVID infection amongst ourselves, and I don't know if anyone else has any other questions they want to add or ask, anything that's popped into your mind. Just raise your hand or just put on your camera and ask Hennie. I'll give you a few moments.
So while we're waiting for any more questions, yeah, once again, thanks, Hennie, for coming. And you know,
Sure.
this is the start of our trauma. Everybody's been COVIDed out by now, and so it's I wouldn't say it's a nice break, but it comes at a time when, you know, the alcohol ban has been lifted and everybody's seeing more trauma. Just for the rest of the guys, this is the start of our trauma. So we're doing, you know, today was a focus on trauma teams, and we touched on some very interesting topics, which we're going to be covering more in depth in the later, in the coming weeks. And if Hennie is available, he's welcome to join on those sessions as well. So we've got Deirdre specifically going to come later in the month to talk about fluids and you know, major blood transfusions and the evidence coming around that, as well as the critically ill trauma patient, you know, things about the endothelial glycocalyx and all kinds of interesting things that she's going to talk about. And then we've also got you know, Conrad going to be talking about acid base and the critically ill, which also leads itself to this lethal triad that people go on about in trauma. And later in the upcoming months, we will focus more on the evidence and those kind of things around EFAS and ultrasound use in trauma, and where we see the role, specifically what it's good for, what it's not. And so we are going to be touching on these things, but I'm glad that we brought a whole lot of it up today. Luke, I don't see any questions coming in for now, and I don't have anything on the chat, so I think we can go along.
Thank you, Hennie. You're welcome
Thanks.
to check out, or you're welcome to just sit in and watch. But take
Take
care and look after yourself that side, and don't bang your head on the wall too much.
Yeah. Thanks. Appreciate the support. Cheers, guys. Bye.
Bye-bye.
Thanks, Hennie.
Thank you, Hennie. So I don't know. So the next part of our session is really just looking at what's happening in people's units. And I sent a message out earlier during the week, just asking for you guys to have a look and to get your guys' thoughts around what we should be doing around decreasing COVID-19 transmission amongst ourselves, but in our units, amongst the nursing staff. I don't know if you're aware, but another reg has tested positive, and obviously more of us will slowly get infected at some point, but it really is about sort of limiting our risk. And I don't know if anyone has any specific insights or what specific things are being doing at different units, or what you're doing in terms of your process in terms of going home, cleaning, because there is some evidence that has come out recently around the infections in KZN at a hospital. I don't know if you guys are aware, there's a big private hospital north of us who have 33 doctors and nurses, and you know that we are at risk, but that we're probably at risk from one another. I don't know if anyone wants to jump on, or whether you just want me to take you through. Cool. So obviously things that we wear, you know, these people are probably not very safe in the COVID environment, but anything that is on your body is potentially going to carry droplets, or and that is a risk both to you and to wherever you take that item. And I know it's very easy to be pedantic about it, but things like rings, watches, bare below the elbows, your hair, it's something we often forget. You know, if you're wearing a mask and you've got goggles on, your hair is also in direct line, and so hair is a risk, and so are things like earrings or anything that you're actually wearing. And so incorporating that into your routine of what you're wearing to work, or what you're wearing home in your vehicle, and what that is coming in contact with will decrease your risk of transmitting infection. I don't know if anyone answered the first poll, but you know, even your shoes, and you know, it's something that you always recognize when you see blood on your shoes. You know they're dirty, you know. But in terms of droplets, shoes are a particularly high risk. We're working in an environment where there's droplets on the floor, there's droplets being spread, and taking your shoes on and off does contaminate your hands, and you take your shoes home, and it's definitely something that we should be incorporating into our practices, actually having a separate set of shoes and washing hands or sanitizing hands between touching our shoes. And then I was just looking at some of the sort of the evidence, and obviously we are aware of how COVID is spread, and that fomites form a part of it, but it's actually not recognized as the biggest form of spread. But I think in terms of inter-hospital spread and what's happening in tea rooms particularly, or places where people congregate, or in public transport or in shared transport, is that we are in environments where we're not using the PPE that we are being provided in when we're seeing patients. And so it's those moments which probably are at times the highest risk to us as staff members, where we've let down our guard and where we're touching something or doing something which increases our risk. And it obviously requires everyone within the team to be pedantic about cleaning, washing your hands. When you're touching surfaces, to have those surfaces regularly cleaned, where there are shared surfaces in tea rooms, or even in recess areas, wherever people are, whatever we're touching, there is risk. And so just regular hand washing is probably the biggest thing that we can do in terms of limiting spread amongst each other. And then obviously wearing masks will also limit spread, but that's sort of the obvious thing. And then, you know, we often, and this is particularly amongst the nurses, and I don't know whether it's something just around infection control practice, or whether it's just, you know, thinking that initially that we will all be fine, or that it won't spread very quickly, but the virus is very contagious. And so wherever people gather, it will be spread, and we need to obviously socially distance, and that includes everywhere. And it's something that we really need to change behavior and change practice. And I think the hospitals that have done it late have been hit hard, and hospitals that think, oh, well, it's still 2 weeks away or 3 weeks away, have been hit hard. And I think those that have changed practice early in some ways are protected. And it's all about trying to maintain a service where we're still able to see patients, where there's still enough nursing staff on the floor, so that the service doesn't sort of collapse in a heap. I don't know if anyone has any insights into things that they're doing. It would be lovely if you can sort of pop the camera on and give us your views. But if you don't, and that's also okay. Lauren, I don't know if you want to add anything sort of around things that we can do, or precautions that we can take, or those of you who are in the midst of it and have to do it on a daily basis, what you are doing.
Thanks, Luke. No, I think there's no need for us to sort of get into an in-depth discussion. Boone, I'll throw to you now. I just saw you popped up on the screen. I don't think there's a need for us to get into an in-depth discussion right now. I'm just really interested in having an ongoing discussion in the next couple of weeks with registrars as a group or individually around the practices that you have adopted, which you think have changed the safety profile that you now fall into. So we want to make sure that you are as safe in the workspace, leaving the workspace, arriving in the workspace, arriving in your home space as possible. And so this is sort of just an introductory discussion around that, and we're going to continue to have those discussions going into the next couple of weeks. Boone, did you have something to add?
Yeah, for myself, one of the main things that I've changed is I've stopped using my phone against my face, and especially the unit phone. If there's an option to put it on speakerphone, I do that. It's just one less thing I have to hold against my face that's been right up against somebody else's mouth. And I feel like those kind of items like mouse pads and mouse buttons and phone receivers and so on are going to be the places where it's closest to our mouths, and if we can keep them clean, number one, and try not to hold them up against our face. Even my own phone, I no longer use it as a phone like this. I just put my phone on speakerphone even when I'm speaking with a friend or whatever, try and be in a private place if it's a private conversation. But that's just something that I've changed for myself, and it costs literally nothing. A lot of units do have a speakerphone. Some units unfortunately don't, and then you have to hold the phone up. But yeah, just one small idea that popped in my head one day.
It's a good idea. It's those are high contact areas, and so I think definitely worth doing. Does anyone else want to add anything that they're doing that they thought, well, that's great, and people around them haven't been doing it? And I don't think so. Okay, so someone's got a hot and cold pocket. There we go. So I think Leo is just sort of suggesting that on his clothing, he needs to be able to keep stuff where he's considered it safe and less safe. And so having a hot and cold pocket is not a bad idea. Remembering that we always still have to end up washing our hands, but it's really about what we bring towards our face. And I don't know about you guys, but I find it very difficult not to touch my face. And probably the biggest thing about wearing a mask is that it reminds me not to touch my face. Anything else? Anything else in the chat? I wasn't able to keep check of the chat while we were going. So plastic bags for phones are great, but it gives you a false sense of security. It does. I used a plastic bag for a little while. So it just washes your phone. And I think Camden sent something out with regards to washing phones or cleaning phones and not necessarily avoiding the warranty. But I was using a plastic bag every day. It was actually just a Ziploc bag, and then I'd throw it away at the end of my shift and have a hot pocket as well.